Great. So thank you. So I'm so happy to be here to be able to, have this conversation. I wanted to again introduce Dr. Richard Price, who's a professor at the University of Virginia, and Dr. Natasha Shibayani, who's now here at Stanford with us, doing some amazing work with imaging. So maybe what we'll do is we'll just start off with some questions. So Dr. Price, what do you think is the reason why, in your experiments, the dendritic cells were maturing in the meninges, but you didn't see this maturation going on in the other parts of the body, like the lymph nodes or the tumor themselves?
Yeah, good question. I'm not sure I have a great answer for it. I think that we looked at a couple of different time points. I didn't talk about the second time point in my presentation. We looked at 2 days and 4 days. At 2 days is actually where we do see that moderate change in dendritic cell maturity in the meninges. We don't see it at 4 days. But it is possible that we are missing some changes in CD86 expression, either in the lymph nodes or in the tumor itself. So that is a possibility. I would probably, posit that I would expect to see that if we were able to get a little bit more granular on our time points. But it also just could be that, you may have a different sort of resident population of dendritic cells in the meninges that are capable of responding to antigen. So if we have reasonable antigen flow into the meninges, but perhaps not much of a change in antigen presentation in the other organs, that could also be a part of that. Of course, dendritic cell maturity is also driven by chemokines. We looked in the tumor for changes in cytokines and chemokines, and we did see transcriptional changes at 6 hours, but not later. So it is possible that in the meninges we actually are seeing more of an environment that's conducive for the maturity of the dendritic cells, but we don't have that kind of protein or transcriptional information from the meninges from this study to sort of fully address that, though.
And did you look at superficial versus the deep cervical lymph nodes when you did that study? And do you notice?
Yeah, so we tried. The lymph nodes that we're looking at in this particular study are the superficial lymph nodes. The deep cervical lymph nodes in the mice are so small, and there's so few dendritic cells in them that we actually really don't get enough of a signal on flow cytometry to make any good conclusions from it. So this is from the superficial.
Okay, great.
Yeah.
I have a question here for Dr. Shibani. Do you have any do you have any ideas on how the antibodies are being trafficked into the tumor after the focused ultrasound?
Also a great question. In fact, I'd say it's perhaps the question that sort of emerged from our study. We certainly weren't able, within the scope of our study, to evaluate fully some of the hypotheses we have, but perhaps I could speak to one that's leading right now. As part of our study, something I didn't get to show is that CD47 and SIRP alpha axis blockade can actually lead to upregulated expression of VEGF-A and VEGF-R2, and this can actually promote tumor permeability. And so despite the fact that we see this sort of persistent increase in antibody delivery, something that we postulate may be happening is that there's actually some interaction between what CD47 is doing to the vasculature, CD47 antibody is doing to the vasculature, and what focused ultrasound might be doing, such that we have this adjoinment that's leading to heightened baseline permeability of the barrier on a longer scale. Now, to assess this, something I didn't get to show is that we actually looked at changes in baseline contrast enhancement within our GL261 tumors. And we actually saw that there was greater leakage of these tumors in this with respect to gadolinium in the group that received FUS relative to the group that received CD47. So this perhaps begins to speak to a sort of combined effect that may be leading to this enhancement post-FUS. I'll also say, we have yet to look at, the immunological sequelae within these tumors, and we certainly have yet to look at the histological level at what we might be doing. But overall, I think this does speak to the fact that questions like this perhaps need to be addressed empirically within the field. And I'll perhaps leave it there for now.
Great. I have another question here for Dr. Price. Given that you saw this reversal of signaling changes at 24 hours versus 6 hours, do you think repeated treatments might produce some of these, may make this longer lasting in terms of inflammatory profile?
Yeah, sure, absolutely. With that said, though, I would like to impress that actually wasn't really our goal in this particular study. So what we wanted to do was use a relatively low level of focused ultrasound. Our mechanical index is only 0.5 here to open the blood-brain barrier, and then look for a sterile inflammation response as well as other immunological sequelae downstream of that. So we weren't necessarily going into this with the idea that we were going to try to drive an immune response. We thought we would see something. We saw some things. We didn't see much, but we saw some things. So that would be my first comment. And then, yes, I do think that would be a way to enhance the sort of inflammatory response that we see at 6 hours. We could repeat the treatment. But, with that said, and we heard about this in the brain tumor discussion this morning from Dr. Liu's group, when you, for example, use a higher mechanical index, so in his studies, he's up at about 0.8 or 0.95, they actually do see some things like increased CD8 effector T cell staining inside tumors. So, perhaps if you're interested in actually trying to drive an immune response, that would be one way to do it, would be using, of course, higher energy. So I guess I'll leave it at there. There might be some other things we could think about, but that would be, if I were, trying to do that in this particular study, that would be a way to address that.
Okay, well, let's follow up on that a little bit. So then, obviously this is, if we were to go to translation with this, right, the findings that you have, and we want to do, try to come up with a therapeutic, then what would you do as your next step for an immunotherapy? Because you said this is a way, just out of curiosity, what approach would you take to make
Which immunotherapeutic approach would I take, or?
Right.
Yeah.
What would you do?
Oh gosh. How much time do you have, Michael? Yeah. Actually, Natasha and I have talked about this for years. It's fascinating to think of all the opportunities out there, and I think it's exciting to see so many groups that are going after these. One thing that I'm really excited about is T cell therapies. I think we have some unique opportunities here. We might have to make the tumors a lot hotter to get CAR T cells into them. TCR transgenic approaches, I think, are going to be exciting, and I think that they'll intersect very well with focused ultrasound. Of course, checkpoint inhibitors are here. Those are in trials now, or they're emerging in trials, and I expect that we'll see some nice successes there as well. If you'll allow me the liberty to continue, one thing that I think might be a little more forward-looking is that I think it's really exciting to think about how this, merging of focused ultrasound immunotherapy and brain tumors is happening at the same time we're learning so much about neuroimmunology and lymphatics in the brain. And sort of the third piece of that puzzle that I find fascinating is that we're starting to understand that we can use focused ultrasound to move fluid around in the tissue, not just in the blood vessels, right? So we have extravascular fluid movement capabilities with focused ultrasound. So you can start to dream up situations where we use focused ultrasound as a tool to actually perhaps change the way the fluid flows in the brain to perhaps get antigen to the meninges or to the draining lymph nodes, which is where we probably want it to be to actually activate these adaptive immune responses. So that's perhaps a little bit more forward looking, but I think there's a lot of interesting opportunities to go in that direction.
Great. Thank you. Dr. Shabani, as a follow-up question, when you showed your sequence, right, you gave the antibody after the focused ultrasound, you saw that dramatic improvement. On your PET scan, we also noticed that some of the other parts of the body seemed to light up, or was that just artifact, like down in the lymph nodes? And can you comment on that?
Yeah, no, I think it's a salient question. And, for our analysis, we really focused on, the tumor bearing regions, even whole brain to some degree. But we actually have yet to start quantifying ROIs within the periphery. And I think, to your point, it will be really promising to look within the lymph nodes, given that we have enough resolution to do that confidently. I think it'll be very interesting, but to speak to what we've seen so far, I can't say that we've quantified anything in the lymph nodes yet.
Okay.
Yep.
But it did, so it was, do you think it was a real finding that that other parts of the body were lighting up? It seems like there was probably a systemic activation.
It's possible. So we've also done automated gamma counter measurements, which I didn't show within the talk, I don't think. And from looking just at ex vivo biodistribution in the organs that you would expect to see uptake in, like liver, kidneys, spleen. We also just looked in the blood. We actually didn't really see any appreciable changes peripherally in the overall levels of radioactivity across the monotherapy or FUS recipient groups. Now, again, the question of lymph nodes is an entirely different one. And in retrospect, I wish I had just removed those and thrown them in the gamma counter as well. But that's to be determined. I think that there are some peripheral organs, to speak to your point about the immunopet images, that do inherently just take up antibody or show radioactive signal on the images. And so there could be some artifact and some noise that we need to remove in order to get at the nuances of something like signal within the lymph nodes.
Great, thank you. I have a question here for Dr. Price. Can you, do you expect a dose relationship between the focused ultrasound stimulus and immunomodulation? Do you think that one should increase the treatment time, or the concentrations of the different agents? I guess the question is do you think there'll be some sweet spot?
Sure. There's a vast parameter space that one could explore. It's a similar answer that I gave to an earlier question about what we were trying to do in this particular study and what you could do. And there's an awful lot of things you could do. One thing I think that sort of intersects with that question well is that we saw this in Dr. Liu's talk, and there's plenty of other evidence that using higher mechanical energy deposition modes may give us a greater response. And perhaps histotripsy would be a way that we can actually elicit one of these kinds of responses. So you could even dream of a situation where we use histotripsy in combination with a much more gentle pulse that eventually could be used to deliver your drugs or your cells after you've elicited enough damage in the tissue, in the tumor, to sort of, as you said before, Michael, like kindle response that you would see later on. So yes, I think there's lots of ways that we can go with that, and I think there's a lot of space that still can be explored.
Good, thank you. Dr. Shabani, so it's interesting that the sequence of the therapy seemed to make a difference, right? And so do you think that this concept of it's almost like a neoadjuvant type of thing where you're going to give the energy before the treatment could apply to other things such as chemo, other drugs, or other antibodies?
I would perhaps answer that question in two parts. So from one respect, I would say, yes, again, I think that this study sort of highlights the importance of maybe certain parameters that we just take for granted within the literature, like sequence of injection relative to focused ultrasound barrier opening. I mean, certainly in sort of trying to contextualize my findings, when I probed the literature further, I did find that across both preclinical and clinical studies that were administering mostly chemotherapies, but in some case antibodies as well, there was this discrepancy in whether the drug was administered before or after FUS. So I do think that it makes a difference, but the thing that I would perhaps caution with our findings is that, at the end of the day, I think our results are, they are perhaps a bit therapy dependent, pathology dependent, and possibly even model dependent. We don't really know that yet. So when you're talking about something like 140 to 150 kilodalton antibody, that might have very different transport properties compared to something much smaller like a chemotherapy. And so while I think that some of the relationships that have been drawn between gadolinium leakage and transport of something like a chemotherapy certainly might reflect something meaningful about drug delivery, we might want to think a bit more about whether that's the same case for something like an antibody, just because antibodies are much larger. So I think that our study sort of highlights that. But in short, I do think that, the notion of when we deliver is helpful to think about irrespective of the size of the therapeutic. And hopefully this will lead to more studies that sort of opt to evaluate that systematically going forward.
Great. Yeah, I mean, I think overall, especially with the immunotherapy, it's such a hot topic of doing this neoadjuvant. So I think it's exciting. I think yours is another example. There was a New England Journal article for lung cancer where they gave neoadjuvant PD-1. So I think that it's an exciting path. I'm glad that you're able to uncover some of those mechanisms.
Absolutely. And I think we're going to see this in forthcoming Q&A sessions and in the panel that, this concept of timing more broadly is being assessed widely within our field right now. It's a really hot topic within the scope of FUS to think about when we should deliver these immunotherapies. But what I'll emphasize about our study is that the time difference was really on the order of minutes, whereas typically with neoadjuvant therapy, we're talking about differences on the order of days in our or weeks sometimes in our rodent models. So I found that to be pretty interesting as well with what we saw.
Great, thank you. Dr. Price, when you did your bulk sequencing, bulk RNA-seq, and you noticed that there was some upregulation, some cytokines, was there anything thematic that you found? Was it a pathway, or was it a myeloid macrophage predominance, or was there T cell predominance of signals that you noticed? Changes.
Well, first of all, it was bulk sequencing, of course, so we don't know where the transcripts came from necessarily, and we do. And actually, one of my students will be presenting some of our single cell work in a couple of days, albeit not on tumors. So I think that's an important place that we need to go going forward, so we can have a better understanding of which cells are making what. We don't quite know that right now. I believe you asked if there was something dramatic. Is that?
Thematic.
Thematic. Oh, okay. So there wasn't much that was dramatic. Thematic, yes, certainly a couple of cytokines, TNF alpha, IL-6 came up. Many chemokines came up. It was interesting. So H2K1 and H2D1, MHC1 associated transcripts came up as well. And that's one of the reasons why we're especially interested to look for staining of MHC1 synfecal peptide to look for antigen presentation in the dendritic cells, although we really saw very, very little there. There was some evidence for that, I believe, in the lymph nodes. So not really a single predominant theme. A lot of things you would expect to see with sterile inflammation, and that's what we were interested in. I think, going into this, we've been over the past 3 years seeing a lot of literature on sterile inflammation response in normal brain tissue, and brain tumors are different. First of all, the cells are already bathed in a little bit of plasma because the vessels are leaky, so it's different than they're starting off different than normal brain tissue would, and of course they're cancer cells. So we didn't necessarily have the expectation that there would be a similar type of sterile inflammation response, even though by and large there did seem to be. So
I think we're about to wrap up, but there's one last question, Dr. Shivani, maybe. I know it's maybe about 30 seconds, but do you know how to explain, can you explain if there's enhanced delivery when antibodies injected before the blood-brain barrier? Would you expect at least some benefit from radiation?
I would, yeah, with respect to radiation forces. I mean, certainly there's a host of literature out there speaking to the fact that with the sort of dogmatic protocol, we can achieve greater antibody delivery, at the very least a therapeutic effect. with FUS. So it's yet to be determined whether this was something CD47 specific in our hands. Again, if it was model specific, but what I can say is that that result was reproducible both by way of PET and automated gamma counter measurements. So there was a slight increase that I think is hard to appreciate from the graph, at least on day 14, the day of barrier opening. So perhaps that speaks to the question a little bit.
Great. Well, thank you so much for your time. You did this beautiful work, and we really appreciated getting time to ask you these questions.